A very good afternoon, everyone. I am Dr. Jayanthi. I am a professor in the Department of Oral Pathology at SCCR Dental College. I am very glad that we are going to have a discussion about a very important topic, especially for the third year BDS students for their university exam, that is the bone disease. Now, without wasting much of the time, we'll directly go into the topic. Now, before we actually talk about bone diseases, you need to know some basics about bone. So we all know that the process of bone formation is called ossification, and we have two types of ossification, as you can see in the picture here: intramembranous and endochondral ossification. So what's the basic difference between these two types of bone formation is that in intramembranous ossification, bone is directly formed by the osteoblast. So the ectomesenchymal cells or the mesenchymal stem cells differentiate into osteoblasts, and that directly forms the bone. However, in endochondral ossification, the word chondro means cartilage. So first, the chondroblast will form a cartilage. This cartilage will act as a scaffold over which bone will form. So the cartilage will get resorbed and then it will be replaced by the bone. And this process is what you call the endochondral ossification. Under microscope, when you look at a normal bone which does not have any disease or pathology, you have two parts of the bone. The outer part of the bone is what you call the compact bone. So you can see in this picture here, the compact bone is structurally different from the inner part of the bone, which is referred to as cancellous bone or the spongy bone. Now, the compact or the cortical bone is supposed to be a little bit thicker, and it is histologically made up of multiple units of osteon. So what is this osteon? Each osteon consists of a central Haversian canal. So what is marked as H1 refers to a Haversian canal. So this Haversian canal is surrounded by bone in concentric layers, and this is called lamellae. And that's how multiple osteons together will form a compact bone. Whereas if you take a cancellous or a spongy bone, you have irregular trabeculae of bone, this pink areas, eosinophilic areas, just trabeculae of bone, which contains bone cells. And then the space in between these trabeculae is called the marrow space, medullary cavity, or what we commonly call the bone marrow. And we know that the bone marrow is very unique and important, and it's a specialist form of connective tissue because hematopoiesis or the formation of blood cells actually happen in the bone marrow. Now, each of this compact bone or the entire bone itself is surrounded by a protective layer. That's what is called the periosteum. And we have two major types of bone cells. One is the bone forming cells, which we call the osteoblasts. They are usually seen lining the surface of the bone. And the second type of cell is what you call the osteoclast, which are bone resorbing cells. And as you can see from the picture here, the osteoclasts are different cells when compared to the osteoblast because they have multiple nuclei. So it's a large cell with multiple nuclei. Therefore, osteoclast is an example for a multinucleated giant cell. Now, with this basics, we move on to the bone diseases per se. Just for our easy remembering, I have just classified these bone diseases based on etiology into 5 groups. So either it can be a developmental disorder, which means as the bone is forming itself, there is some pathology that's happening in the bone. That's called developmental bone diseases. You have inflammatory diseases, fibrosis lesions, metabolic bone disorders, and of course, tumors or neoplasms occurring in the bone. Now, these inflammatory bone diseases will include a subset of disease called osteomyelitis, and that will be dealt separately for you. Similarly, the neoplastic or bone tumors, which include benign tumors like osteoma and malignant tumors like osteosarcoma and Ewing sarcoma, is also dealt separately in the chapter benign and malignant tumors. The metabolic bone disorders is a separate group of diseases where in different hormone variations as well as in vitamin deficiencies, you get a lot of changes in the bone. And to specifically mention, we have vitamin D deficiency, which is called rickets, which can show a lot of bone changes and pathology, as well as excessive level of parathormone level in the blood or serum, which is called hyperparathyroidism, can also show bone changes. So these 3 things, the inflammatory, metabolic and neoplastic, we are not going to discuss today due to lack of time. We are only going to focus on 2 important ones, that is your developmental bone diseases and your fibrous lesions. And kindly remember that I am only focusing on the exam point of view, because of course this is only for the exam going students. Therefore, only those that is very important, either for Viva during your practical exams or for your written theory exams, the questions that are frequently asked in the exam, I am focusing on only those topics. So the developmental bone diseases are mainly syndromic. So you all know what a syndrome is just multiple symptoms together occurring in the same patient, in which bone involvement is also one feature. So the first one in that will be your Peary-Robin syndrome. So the main three features of Peary-Robin syndrome is, you can see the picture of the child here, the mandibular micrognathia. So what is the meaning of that? The mandible is very small. That is the primary problem. So because of that, what happens? The mandible is not growing forward. As a result of that, the two palatal shelves embryologically are not fusing with each other, resulting in cleft palate. And because of that, the tongue is not resting on the floor of the mouth. The tongue will fall back and it will obstruct your respiratory tract. And that condition is called as glossoptosis. Mandibular micrognathia leading to cleft palate, which in turn leads to glossoptosis. All these three features, if a same patient is manifesting, then you call that condition as a Peary-Robin syndrome. Now, recently, rather than calling this condition as a syndrome, people prefer to call it as anomaled, because one event, which is a primary event, in this case, the primary problem is mandibular micrognathia. That primary event is leading to a secondary event, that is your cleft palate, which is leading to another event, which is glossoptosis. So one event or one problem is leading to the other problems. Therefore, it is preferable or better to call this condition as Peary-Robin anomaled rather than calling it as a Peary-Robin syndrome. The next one in developmental disorder is again a syndrome, which is Treacher syndrome. So two different researchers called Treacher and Collin first described this. And please note that in each of this syndrome, there is a genetic abnormality, which means a particular gene is supposed to be mutated or abnormal, which is leading to this condition. For undergraduates, these gene mutations are not very important. So I'm not focusing on that. I'm primarily focusing on the clinical features. Now, in Treacher syndrome, the child or the affected person is having a characteristic face. Here, it is a bird-like faces. So, the patient is having hypoplastic zygoma. So, the prominence of the zygomatic bone is absent here. So, the patient will be having a flat zygoma. Other than that, there is also anomalies in the eye as well as in the ear. So, what's the problem in the eye? In the eye, there will be notching on the lower eyelid. And this condition is called coloboma. And when you come to the ears as such, the external ear or the pinna is showing a lot of developmental anomalies. In addition to all that, the patient is also having an underdeveloped mandible, similar to what you saw in Peary-Robin syndrome. So please remember these two conditions. Number one, Peary-Robin syndrome. Number two, Treacher syndrome. The common feature to both this is mainly there is underdeveloped or small mandible. That is the primary bone problem in these patients. So whenever you take a radiograph, because this mandible is not developed properly, the condylar process and coronoid process of the mandible will show hypoplasia. Therefore, the antigonial notch will be very prominent. That can be appreciated in the radiograph of these patients. The next syndrome that is again very important from the exam point of view is Marfan syndrome. As you can see from the picture here I have put is the picture of former US President Abraham Lincoln, because he was supposed to be having this particular disease. So if you remember his picture, the clinical features of all this can be easily understood. And that's why I have put this picture. So just a minute. Okay. So here the problem is there is a gene called fibrillin gene, and that gene is muted. So what happens because of that? You don't only get skeletal problems, but you also get muscle related issues. So the face will be very typical, long and narrow face, and there will be hyperextensibility of the joints. And the patient also has cardiovascular abnormalities and changes in the eye in the form of cataract, myopia, and retinal detachment. When you come to the intraoral findings, the two important findings that you see in patients with Marfan syndrome is bifid uvula, that is the uvula will be turned into or converted into two small structures. That's called bifidula, and also the high arch palate. The palatal vault will be very high and narrow. These are the two intraoral findings that you see in Marfan syndrome. The next one is cherubism. So cherubism is again from exam point of view, very, very frequently repeated question in the exam. So the word cherub itself means that a child with chubby cheeks. So in the old Renaissance paintings, there is a lot of depiction of small children. Typically, all these children will be having round, small face with chubby cheeks. They are called as cherubs. And in this particular bone condition, there will be bilateral enlargement of the jaw bones. So the patient will clinically manifest with chubby cheeks, and that's why the name cherubism is given for this. This is also a developmental condition, and there is a genetic mutation in a gene called SH3BP2 gene. So if you can remember, it's well and good. If you don't remember this, it's not very important. So don't worry about it. Okay. So cherub-like faces is nothing but because of bilateral swelling of posterior region of mandible. And in addition to that, depending on the severity, some patients may also get involvement of the maxilla. So the maxilla will be involved. So the orbital floor and the infraorbital rim will be enlarged. So as you can see in the picture, this will give an appearance of eye upturned to heaven appearance. So which means that it will look as if the patient is staring upwards. That is because of enlargement of the orbital floor and infraorbital rim. So that's a very characteristic feature of cherubism. So when you take a radiograph, now this is very common in children, right? And please remember one more important thing. Most of these developmental disorders, not only of bone, of any other system, it is a developmental disorder, right? So it occurs during the developing phase. So you most commonly start seeing the signs and symptoms in children itself. That is a very unique feature of all the developmental disorders, including bone. So even in cherubism, the manifestations are seen more commonly in children. And because it's a growing phase, teeth are still erupting and shedding. So if you take a radiograph, this is orthopantogrammetry view, you can see in this picture that because of swelling of the mandible, there will be multilocular radiolucencies seen in the posterior region of mandible if you take a radiograph. As a result of that, the teeth will not be having any bone support because the bone is destroyed, right? That's why you're getting a radiolucency. So it will look like as if all the teeth are floating in air. There is no bone support. There is no alveolar bone process. The teeth are just floating in air. So the typical radiographic appearance of cherubism is referred to as teeth floating in air appearance. That is because of bone destruction and radiolucency. And another thing that you need to know is, suppose you take a biopsy and look this tissue under the microscope. So what do you expect to see? You see a lot of multinucleated giant cells. So cherubism is considered to be an example of a giant cell lesion of the bone because microscopically you're seeing a lot of giant cells. So what are these giant cells? They are nothing but osteoclasts. So you remember I told you in the beginning of this class itself that you have osteoclasts, which are bone resorbing cells, and these cells are multinucleated giant cells. So whatever you're seeing here microscopically, these multinucleated giant cells represent nothing but they're all osteoclasts, and they are responsible for the bone destruction. Because of bone destruction only, you are seeing the radiolucency in the radiograph. In addition to that, you also see a vascularized fibrous connective tissue surrounding the bone, and there will be a eosinophilic cuffing of bone. So the next developmental disorder is called Cleto Cranial dysplasia. Now the word Cleto means clavicle. Okay, so cranium means skull. So here, the two major bones that are involved in this particular disease is, one is clavicle, the other one is the skull bone. And that's why the name is Cleto Cranial dysplasia. And there is a defect or mutation in a gene called CBFA. Now, what is the CBFA? The full form of CBFA is core binding factor alpha. How is it related to bone? Is that I said that in membranous ossification, the osteoblast will form the bone directly. But where is the osteoblast coming from? The osteoblast is originating from Mesenchymal stem cells. Now, the mesenchymal stem cells not only give rise to osteoblasts, they also give rise to other mesenchymal or connective tissue elements like your muscle, blood vessels, nerve fibers, fibrous tissue, adipose tissue. All the connective tissue elements are forming from the same mesenchymal stem cells. So, for bone formation, specifically for bone formation, you need a factor. That factor is called core binding factor alpha, which means that without core binding factor alpha, osteoblasts cannot form from the mesenchymal stem cell, and therefore bone formation cannot happen. So this CBFA or core binding factor alpha is very, very important for bone formation. In patients with cleidocranial dysplasia, there is a mutation in this gene, so bones are not forming properly. All the bones will be affected naturally, but it is very obviously clinically evident in two bones. One is the clavicle, the other one is the skull bone. So what happens in the clavicle? The clavicle will be either totally absent or it will be small or hypoplastic, not developed properly. And because the long bones are affected, the patient will be having short stature, the height will be reduced. And there will also be frontal and parietal bossing. And what is happening to the skull? In the skull, the sutures are having delayed closure. Now, this is a very important feature because the fontanelles, anterior and posterior fontanelles, as well as the suture, there is a particular time when they will fuse and bone maturity will occur. But in patients with cleidocranial dysplasia, that is getting delayed. Okay. And when you come to the oral cavity, there will be prolonged retention of deciduous teeth and the permanent teeth will not erupt at the right time. So when a radiograph is taken for these patients, you can see this picture. There are multiple teeth here. So the patient is having multiple supernumerary teeth. Supernumerary teeth are nothing but extra tooth. So multiple supernumerary teeth are present because they don't have space to erupt. All of them will be impacted. Therefore, multiple impacted supernumerary teeth is a very, very classical feature of cleidocranial dysplasia. So when the researchers went back and checked the reason why the teeth are impacted or why there is a delay in the eruption of permanent teeth, they found out that histologically, the teeth in these patients lack cementum, especially the secondary cementum. And if you all remember the first year oral histology, there are some theories of tooth eruption. There is something called root formation theory, or in other words, only when cementum deposition and root formation happens properly, eruption will take place at the right time. These teeth are not having cementum, therefore root formation is affected, and that is one reason why the eruption is affected in these patients. Now, please remember in 3 marks question or in 5 marks question, they will ask about cleidocranial dysplasia. Similarly, another important question which can be asked as a 3 mark or 5 mark question in the exam is osteogenesis imperfecta. Again, you need to know about the mutation here. So all the other disease, if you don't remember also, it is fine. But for cleidocranial dysplasia and for osteogenesis imperfecta, please remember the name of the gene that is mutated. In case of cleidocranial dysplasia, I already mentioned the gene is core binding factor alpha, which is needed for osteoblast differentiation and bone formation. In osteogenesis imperfecta, the mutation is happening in collagen 1 gene. So we all know there are 29 different types of collagen in the human body. But in osteogenesis imperfecta, only one type of collagen is affected, that is type 1. So where do you see type 1 predominantly? Predominantly, you see it in the bone and in the teeth. In the teeth, dentin and pulp and cementum, all these structures except enamel. Enamel is not having collagen. Except enamel, all the other structures of the teeth are also having type 1 collagen. Therefore, in osteogenesis imperfecta, the name is telling osteogenesis imperfecta, which means bone formation is not proper, imperfect. But in addition to bone, even the dentin will be affected because type 1 collagen is not seen only in bone, it is also seen in the dentin. So the two important features of this disease is bone is not formed properly. Even if it is forming, it is very fragile. Therefore, there is an increased tendency for bone fracture and breakage. And second thing is the teeth, dentin is affected. So the dentin is not formed properly. So that will result in opalescent appearance of the teeth. That's what you're seeing in this picture here, opalescent appearance of the teeth. And the third and the most important feature of this disease is the patient will have blue color sclera. It's not that the sclera is turning blue. It is that the underlying choroid's color, normally behind sclera, you have a layer called choroid in the eye. The normal color of choroid is blue color. In a normal patient, the sclera thickness is good enough so that the underlying color of the choroid is not reflected. Whereas in patient with osteogenesis imperfecta, because of mutation of type 1 collagen, sclera is also having type 1 collagen. So the sclera thickness will become very less. Therefore, the underlying choroid color will be reflected, and that is why you are seeing blue color sclera. So bone fragility, opalescent dentin, and blue color sclera are the three important features in osteogenesis imperfecta. And just for a theoretical point of view, based on the severity and also based on the mode of transmission, you have 4 different types of osteogenesis imperfecta, type 1 to type 4. And another point I would like to say here is, maybe in Viva they might ask, this blue sclera, in which disease is it seen? So the answer is osteogenesis imperfecta, but it is not unique or exclusively seen only in osteogenesis imperfecta. You also see it in other bone diseases. Like example, you can see sometimes in Marfan's disease. You can also see in a normal, healthy newborn individuals. So even in other diseases also, it is possible to see blue sclera. The next one is Paget's disease. Now, the other name for Paget's disease, of course, James Paget is the scientist who first described this, so it's called Paget's disease. The older name or the other name for Paget's disease is osteitis deformans. So why is the word osteitis used here is because the affected bone, when you touch it, it was very warm, and increase in the temperature, local temperature or warmth was considered to be one cardinal sign of inflammation. So initially people thought that this is an inflammatory disease of bone. So they called it as osteitis deformans. Later they realized that it is not an inflammatory disorder. Then what is it? Or in other words, what is the etiology for Paget's disease? Although I have put this under developmental disorder, this is not a developmental disorder, which means you don't find any gene mutation in this particular disease. So it is not genetic. I already mentioned it is not inflammatory, it is not infectious. Then what is the etiology? The exact etiology or cause for Paget's disease is not yet identified. Different researchers are suggesting different causes. Some people are saying it may be because of some viral infection. Some of them are saying because of radiation. Some of them are saying it is because of some endocrine abnormalities, but nothing is proven till now, and therefore the exact etiology is still unknown. But what do we know about Paget's disease is that the remodeling of bone is affected. So what do you mean by remodeling of bone? So we have 2 types of bone cells, right? Osteoblasts, which form bone, and osteoclasts, which resorb bone. So in a normal healthy adult person, resorption followed by deposition is happening in a cyclic manner, and this process is called bone remodeling, which is not abnormal, but it is normal. However, as you become older and older, the remodeling capacity is decreasing. That's all. But in patients with Paget's disease, the remodeling itself is abnormal, which means the resorption is also abnormal. The deposition of bone is also abnormal. Both are abnormal. That is what is happening in Paget's disease. But why is it abnormal? The etiology is not known. We only know that the remodeling of bone is abnormal or affected in Paget's disease. So you get this more commonly in older adults. Now all this time, whatever diseases we were discussing till now, they were all developmental diseases. Peary-Robin syndrome, Treacher syndrome, Cherubism, Cleto Cranial dysplasia, they're all development. All of this disease had a genetic mutation, and all of them commonly manifested in children. In contrast, Paget's disease is not a developmental disorder. There is no gene mutation. It's commonly seen in older adults, and men are more affected than females. So because of abnormal bone remodeling, the bones will become enlarged and thickened, but still they will be very weak. Don't think that because the bone is very enlarged and thick, it will be very strong. Nothing like that. It will be enlarged, but still it will be very weak. So when you take a radiograph, you have two phases for this disease. One is abnormal resorption phase. The other one is abnormal deposition phase. So if you take a radiograph in abnormal resorptive phase, bone is getting resorbed, right? So what will you see? You will see radiolucency. And this radiolucency, which is well defined, is described as osteoporosis circumscripta. Why is the word circumscripta used? Because the radiolucent defect is well circumscribed. Okay. Whereas if you take the radiograph of the affected bone in the abnormal deposition phase, what will you see? You will see radio opacity. Correct? So this radio opacity is referred to as cotton wool appearance because it will look as if you have placed a bunch of cotton. You can see this picture here, the radiograph I have shown. So there will be abnormal radio opacity because of excessive deposition of bone, and that is described as cotton wool appearance. So please note, students, in a Viva question, very frequently repeated question, the favorite question for examiners is, in which disease do you see cotton wool appearance in the radiograph? And the answer will be Paget's disease. Okay. And another important thing about Paget's disease you should know is, one finding that you can see in these patients is all the teeth, not in one or two teeth, all the teeth will have abnormality in the cementum. Okay. So what is that abnormality? You will see hypercementosis, excessive deposition of cementum will be seen in all the teeth. So generalized hypercementosis is again a very important feature in patients with Paget's disease. So this is about the radiographic appearance. So if you take biopsy of the affected bone and you look under the microscope, what will you see histologically? You will see abnormal resorption with lot of Jayanthi cells representing osteoclasts. You will also see abnormal formation of bone. So this alternatively resorption and deposition of bone is referred to as mosaic pattern of bone, which is also called as jigsaw puzzle appearance. So why is it called mosaic? You all have seen a mosaic floor, right? You have some patches that are black, some areas that are white, correct? So which means it is not uniform, but it is showing some variation. That's what is called mosaic pattern. So the same way, if you take Paget's disease affected bone and look under the microscope, you will see some areas of resorption and you will see some areas of abnormal deposition. And that is why the bone is referred to as having a mosaic pattern here. And another important diagnostic or characteristic feature of this disease is that if you collect serum from these patients, classically, there will be increased level of one particular enzyme, that is alkaline phosphatase enzyme. So you all know that alkaline phosphatase is an enzyme that is associated with osteoblasts and bone. So in this particular disease, you can see increased level of serum alkaline phosphatase. Most of the time that helps in the diagnosis of Paget's disease. And you need to also understand that Paget's disease, you can have only one single bone that is affected, which you call it as a monoosteotic type, or in rare cases, you also have multiple bones that are affected where you call it as a polyosteotic type. And it is very, very commonly seen in the older adults. So what is the treatment for Paget's disease? In all the other developmental disorders, they are all syndromes, they are all genetic disorders. So you cannot do anything about it, right? You cannot modify the gene as of now. The researches are still going on that, but as of now, all the genetic diseases, there is no specific treatment for that. Okay, but in Paget's disease is not a genetic disease, right? So what is the treatment? Here, the bone remodeling is abnormal. So you need to give some drugs that will control the abnormal resorption of bone. So you have a group of drugs called bisphosphonates. Okay, these drugs act by inhibiting the resorption of bone. So all the abnormal resorption of bone can be controlled by giving bisphosphonates. And majority of the patients, older patients, who are having Paget's disease for a longer duration, they are all on bisphosphonate therapy. So we have completed the developmental disorders of bone now. Quickly, we will move on to the next important topic, that is fibrous lesion. Now, when you come to fibrous lesion, this is very important because most of the times the essay question is asked in this particular topic. So the question goes like, classify fibrous lesion, write in detail about fibrous dysplasia. This is like almost repeated in all the question papers, not only in Kerala University of Health Science. Even if you check the other university papers of Tamil Nadu or Bangalore or even in North India, this is a very, very important question that is frequently repeated for third year BDS. So what are these fibrous lesions? So the name only suggests there are two terms here, fibro-osseous. So what happens is it's a bone disease. So the normal bone is resorbed and it is replaced by fibrous connective tissue. That is the first step. So the first step is the normal bone will be resorbed. It will be replaced by connective tissue. What is the second step? In the second step, the connective tissue that is formed here, the fibrous connective tissue, will start depositing new bone, new mineralized component or a new bone. So this type of lesion, they are called as fibrous lesion. So it is not one single lesion, it's a group of a lesion. So you have a classification for that. And this classification is, of course, an old classification given by a person called Waldron. So if a question is asked, you can write this classification of fibrous lesion by a person called Waldron. So according to Waldron, fibrous lesions are of three types. One is developmental, the second one is reactive, and the third one is neoplastic. So in developmental, the name of the disease is fibrous dysplasia. So developmental can also be called genetic because there is a genetic mutation in this particular disease. Reactive, the name of the disease is cementosseous dysplasia, and neoplastic means tumor. It's a benign neoplasm and it is called ossifying fibroma. So we have three different types of fibrous lesions. Please remember, all these are having a common pathophysiology or pathogenesis. What is that? That is the normal bone is resorbed and replaced by fibrous connective tissue. And this fibrous connective tissue is forming a new bone. This pathological process is common for all these three diseases. So how are they different then? They are different in clinical features, radiographic features, and histopathological features. Only these three features you have to correlate together and then come to a diagnosis, whether it is fibrous dysplasia or cementosseous dysplasia or ossifying fibroma. So you need all the three. You cannot tell which is more important. You cannot tell only with clinical and radiograph. You need clinical, radiographic features as well as histological features to come to the diagnosis. Now, why do you have to diagnose it as three different lesions? Why can't you just tell it is a fibrous lesion? Why is it important that you have to tell specifically if it is fibrous dysplasia or ossifying fibroma? Because the prognosis and treatment is slightly different for all these three diseases. Okay, so the number of times you will follow up the patient, the type of surgery you will do, or the extent of bone you will remove, all that will be different. Therefore, it is very important for us to know which particular type of lesion it is. We cannot just give the diagnosis as fibrous lesions. And for your completion of classification, this lesion, cementosseous dysplasia, is again further classified into three subgroups: focal, periapical, and florid. Okay, so today we are not going to discuss about cementosseous dysplasia or ossifying fibroma because of lack of time. They are not usually asked. Usually the most commonly repeatedly asked question is fibrous dysplasia. So I am focusing on only that and I'll be telling in detail about fibrous dysplasia. So as I already told, fibrous dysplasia is a developmental type of fibrous lesion. So there is a genetic mutation there and the gene that is mutated is called GNAS, G-N-A-S, GNAS. Okay, that is the gene that is mutated. The full form of GNAS is guanine nucleotide with alpha stimulating activity. I'll repeat once again, guanine nucleotide with alpha stimulating activity is GNAS gene, which is mutated in patients with fibrous dysplasia. So when this gene will get mutated, at what level, depending on that, the clinical features will be slightly different. I'll tell you that later. Just know that fibrous dysplasia, number one, is a fibrous lesion. Number two, it is a developmental type of fibrous lesion and it is having a mutation in a particular gene called GNAS. And it is more common in children or adolescent age group because I already mentioned that all the developmental disorders commonly manifest in children. When you compare the jaw bones, maxilla and mandible, maxilla is more involved than the mandible. You can see in the clinical picture here, there will be a swelling of the maxilla or enlargement of the maxilla. That's a characteristic clinical feature. Now you have two types here, monoosteotic, polyosteotic. As the name suggests, Monoosteotic means only one bone is affected, whereas polyosteotic means in the same patient itself, multiple bones are affected. So in addition to jaw bones, you can also see involvement of the femur, long bones, vertebra, skull bones, hip bones, multiple bones can be affected in these patients. So in the polyosteotic type, there are three syndromes that are seen in association with fibrous dysplasia. They are called McCune-Albright syndrome, Jaffe syndrome, and Massey-Broad syndrome. Now, what is this McCune-Albright syndrome? If a patient is having polyosteotic fibrous dysplasia, along with that, there is endocrinal abnormalities. It can be pituitary abnormality or a parathyroid or adrenal gland abnormality, or there may be abnormality in genital development like precocious sexual development, all that. So if there is an endocrine abnormality plus pigmentation of the skin, and this pigmentation is given a specific name that's called cafolate spots. Okay, cafolate spot means the meaning is coffee with milk. Cafe means coffee. Cafolate spots means coffee with milk. When you mix coffee with milk, you will get a brown color. So wherever you see brown color pigmentation, a specific name is given, especially in McCune-Albright syndrome, that is called as cafolate spots. And if a patient is having polyosteotic fibrous dysplasia, endocrine abnormalities, and cafolate spots, all three together, then you call that syndrome as McCune-Albright syndrome. However, if the patient is having only polyosteotic fibrous dysplasia and cafolate spots, no endocrine abnormalities, then you call Jaffe syndrome. If there is polyosteotic fibrous dysplasia with the myxomas, then you call that as syndrome as Massey-Broad syndrome. So please remember, the syndromic association is only seen in polyosteotic fibrous dysplasia where multiple bones are affected, not in monoosteotic types. And just for your reference and information, the cafolate spot or the brown pigmentation that you see in Albright syndrome and Jaffe syndrome is also seen in another disease, a third disease, that is called neurofibromatosis type 1. That is also an important question for you in the exam. It can be asked in the Viva. In which diseases cafolate spots are seen? The answer will be number 1, McCune-Albright syndrome, number 2, Jaffe syndrome, and number 3, it is neurofibromatosis type 1. In all these three diseases, you can see cafolate spots. So in any bone diseases, even before you go and take a biopsy and look at the microscopy, radiography or CT scans are very, very important. It will tell you the extent of the lesion. It will tell you the involvement of the additional vital structures or surrounding structures. So you have to definitely go in for a radiograph before, or a CT scan before you go for a biopsy. So in fibrous dysplasia, if you take a radiograph, there are 3 phases that you see. In the first phase, bone is getting resorbed, right? So when his bone is getting resorbed, you see radiolucency. So you will only see a radiolucency. In the next step, the resorbed bone is replaced by fibrous connective tissue, and this connective tissue is forming new bone. Then you will see a mixed radiolucency and radiopacity. In the next step, complete bone formation will be seen. So totally you will see a radioopaque lesion. Therefore, depending on the stage of the disease, the radiographic features will change. Okay, so in the very initial phases, you will only see radiolucency. In the later or advanced stage, you will see only radiopacity. In between, majority of the times, what you see is mixed radiolucency, radiopacity. In fact, whenever you take a radiograph, you see a mixed radiolucency, radiopacity in the radiograph, and you know that there is a bone enlargement. The first differential diagnosis you should consider is always a fibrous lesion, because the most common lesion that will produce a mixed radiolucency, radiopacity will be a fibrous lesion. Okay, so when you have a complete radioopaque lesion, this opacity is also described as ground glass appearance. So now you see the picture here, the bone is very opaque and dense because of radioopaque appearance. So that appearance is called ground glass appearance. That's a very classic radiographic appearance in fibrous dysplasia. So if you see the textbook, it's also mentioned about something called Rind sign. So what is this Rind sign? Please remember, the Rind sign is only very prominent and obvious in the long bones like femur. You don't get to see Rind signs in the jaw bones. Okay. But what is this Rind sign is that if there is an initial stage of radiolucency. Sometimes this radiolucency will be lined by a thick sclerotic border. That thick sclerotic border is referred to as rim design, which is obviously seen in the femur or the long bones. So the next process you will do is you will go in for a biopsy and look at the microscopic examination of the tissue. What will you see? You will see two important parts here. One is the bone, that is the pink or hematoxyphilic areas. The other one is the connective tissue. So if you ask me, which is abnormal here, the bone is abnormal or the connective tissue is abnormal? The answer is both are abnormal. So remember that the bone that you see here is not the normal bone of that area, but it is the abnormal bone that is formed by the fibrous connective tissue. Therefore, in the microscopic appearance of fibrous dysplasia, you will see first immature oven bone. So this immature oven bone is seen or arranged in a specific pattern that's called Chinese letter pattern. So you can all go and check Google images how Chinese script will be. Most of this will be having a curved appearance. So which means the bone is having a curved appearance or C-shaped appearance similar to Chinese letter pattern. So this bone is called as Chinese letter pattern. What type of bone is it? It's an immature oven bone that you see here. And you don't see the osteoblastic rimming in this bone. So I showed you in the first picture. The osteoblasts are cells that are lining the bone. But here in fibrous dysplasia, this immature oven bone does not have a osteoblastic rimming. And you see a connective tissue that will be a cellular fibrous connective tissue. So you see both connective tissue as well as bone here. The connective tissue will be a cellular fibrous connective tissue with lot of fibroblast and cells, whereas the bone will be an immature oven bone which is arranged in Chinese script pattern without an osteoblastic rimming. So if you see a patient who is ranging a child or an adolescent age group comes to you with a swelling of the maxilla predominantly or sometimes the mandible also, then you take a radiograph. You are seeing either a mixed radiolucency, radio-opacity or a radio-opaque lesion having a ground glass appearance. You go in for a biopsy and under the microscope, you see an immature oven bone without an osteoblastic rimming with a cellular fibrous connective tissue. Then your final diagnosis will be fibrous dysplasia. Okay, so you have diagnosed it as fibrous dysplasia. What do you do then? Actually, there is no specific treatment because again, this is a genetic problem, right? There is a mutation in gene. So if there is a mutation in a particular gene, you have to do a genetic modification or genetic therapy. So there is no actually specific treatment for this. Only thing is you need to remember when the child gets the swelling first, the swelling will keep growing as the child's bone and age is going on. So once the child attains skeletal maturity, the growth of the bone will also stop. So even if you're planning to do some aesthetic correction, that is trimming of bone, recontouring of bone, all that can be done for aesthetic correction, right? Otherwise, the child will be, or the person will be having one side swelling and deformity will be there. So aesthetically and psychologically, they'll be having an issue. So to overcome that, recontouring of bone can be done, but it is not advisable to do that in the initial stages. Wait for it. Wait for the lesion to stop growing. That will usually happen when the child's growth is arrested by 18 years or 19 years. After that, aesthetic recontouring and surgical shaving of the bone can be done. Otherwise, you don't have to worry much about it. It's not a problematic condition. It is only a developmental disorder. So no specific treatment is required for this. So fibro-osseous lesion, I've mainly covered fibrous dysplasia. So most of the times the question is focused on fibrous dysplasia. But please remember you also have other conditions, reactive lesions like cementosseous dysplasia and benign tumor like ossifying fibroma. So just go through what is the difference between fibrous dysplasia, cementosseous dysplasia and ossifying fibroma. Just know the difference. Otherwise, from theoretical point of view, this is what is very frequently repeated for you in the exam. So with this, we come to the conclusion of bone diseases. I know I have been very fast and quick because I didn't want to waste time and we had a lot of lesions to cover. Please remember, I have only focused on the exam point of view and given tips and important points for Viva as well as for theory exams. There are few other bone lesions which are not very important from the exam point of view, so I have not included that in my presentation. I think this, if you know these lesions very thoroughly, you would be able to confidently write the answers with this particular topic. And I wish all the best to all these students. Your exams are upcoming. Prepare well. And you also have tips on how to prepare and write the exams also by Dr. Jiju. So I would take this opportunity to thank the entire team of Annoor Dental College, specifically my good old friend Deepu and his team, Dr. Priya, Nirupa, and all the others for giving me this wonderful opportunity to interact with you people. Thank you all so much.